Okay. Any other questions about mitosis, meiosis? Well, then let's finish up talking about making sperm. Okay. And then we're going to move on into the girl parts. Okay. So the different terms. Okay. Spermatogenesis is making the sperm. Okay. Then we've got spermiogenesis is the changing from being a spermatid into the shape of a spermatozoan. And spermiation is when these guys drop off into the lumen. Okay. So just to recap, in the process of spermatogenesis, in other words, this part going from my diploid spermatogonium to my primary spermatocyte, where I've gone through into meiosis one, and I'm still diploid. So I still have everybody, all the chromosomes with all of the alleles. So, and that's where I've got my synapses with my tetrad formation and my possible crossover to increase the amount of variability and what the possible combos are in order to make my next generation. Okay. When I divide at the end of meiosis one, now I have my secondary spermatocytes. When they go through the finish of meiosis two, then I've got my 4 spermatids. That's as many as I get. I'm done. So my secondary spermatocytes and my spermatids are both haploid because they have either mom's or dad's version of every trait, ignoring the recombinant chromosomes that are the result of crossover. Okay. But these guys only have one version for every trait. Okay. So haploid still has double the amount, but still only one mom or dad version for everything. This is haploid, but it has one gene for every single protein we need to make, right? So we've gone from 1 to 2 secondaries to 4 spermatids. Each spermatid, then, we're done with meiosis. There's no more division at all. But each spermatid is going to go through a reorganization process, okay? So this is the spermiogenesis process. This is where I have to shift all the stuff that I need into the right places, and then I'm going to ditch the extra stuff I don't need. This whole process has been supported by those sustentacular cells, okay, the Sertoli cells, because they are using the testosterone to help with this whole process, okay? And when I go from a spermatid to a spermatozoan, I've gotten rid of everything except DNA, a cap that has proteolytic enzymes, the acrosomal cap. I've moved all my mitochondria into this mid piece here. And then I've grown out and created a flagellum to get to where I need to. I'm hoping the egg. Okay. So all the rest of the stuff, endoplasmic reticulum, ribosomes, all that other stuff has to be absorbed by the Sertoli cell. So if I look at this guy, this is where it's all happening. So it's this process of spermatogenesis and spermiogenesis, that metamorphosis, kind of like I took a caterpillar and turned it into the butterfly. These things are all supported by these sustentacular cells. So to give the sustentacular cells their kind of full due credit, things that are helpful to understand about them is that they hold on to each other by tight junctions. Okay. So what they do is they have basically, we've got these spermatids are kind of in this whole process of spermatogenesis, all these cells are going to become the spermatids and then the spermatozoa. They're kind of buried within that cytoplasm of the sustentacular or Sertoli cells. Okay. They have tight junctions holding each other to holding each neighboring Sertoli cell to each other. So another thing that happens with these guys is not only are we allowing for this process and encouraging it by using the androgens, testosterone being the main one, but it sets up a blood testis barrier. And remember when we talked about like the blood brain barrier, you did that in ANP1, and this was one of the things I mentioned too. These, you cannot let your immune system see these cells because they do not look the same. I mean, a sperm or an oocyte, they do not look the same. They've gone through meiosis. They are not the same. Your immune system would say, oh, not the same. And it would absolutely attack them. So these sustentacular cells or Sertoli cells, their job is to maintain the blood testis barrier so that your blood does not get to see these weird cells and then attack them. Okay. It's helping with the maturation process. It's supporting it. It provides nutrients. It's going to absorb the unwanted extra stuff from these spermatids as they metamorphose. Spermiation is next. So these things are all happening because of these Sertoli cells. So they kind of get a big bow. They form the wall of these seminiferous tubules. They also, down at this end, are going to secrete testicular fluid because when you release these spermatozoa at the end in the process of spermiation, then they don't have mobility. They just have to float with the current. So the current is created by a constant production of the testicular fluid. Okay. They also secrete some proteins, something called inhibin and another thing called androgen binding protein. And the inhibin is inhibiting the pituitary from making FSH and gonadotropin releasing hormone from the hypothalamus. And the androgen binding protein is about binding to testosterone in the testicular fluid, so it increases testosterone in the tubules, which helps with the process of spermiogenesis. Does that make sense? That's a big list of things for the resume of the sustentacular cells. All right, so we've gone through the process of making these spermatozoa, then we pop them off into the lumen because the cool thing is, and this is what was cool with a microscopic view, is that when you're trying to identify these cells, it's all about location. Remember with the endocrine glands, like with the adrenal cortex, it was all about, okay, right underneath the capsule, you know, it was zona glomerulosa. Below that big one, lighter, was zona fasciculosa. So it's the same thing. I follow down and it's always going to be in the same order. Amanda, your cat cracks me up every time. She's too cute. Sorry. All right. Anyway, squirrel. So we get let loose into the lumen of the seminiferous tubule. We're now swimming around. Well, we're not swimming. We're floating around. Excuse me. We're not swimming. We're floating around in this testicular fluid. Okay. Then there's this constant production of testicular fluid, which makes these guys flow through the seminiferous tubules until we get sort of along the current and we get into those little straight tubules to the rete testis. I mean, we're just passively, it's like being on an inner tube and floating down the Rainbow River. Okay. All right. So if we look at a spermatozoan, which by the way, in your books, all this stuff is on 1056 and 1057. So you can see the rearrangement that's going on in the process of spermiogenesis, this metamorphosis from a little round spermatid turning into kind of a torpedo-shaped thing or a bullet-shaped, and then finally we become the mature sperm. So when you look at the sperm, you see that you've got the head containing the DNA, and you've got the acrosomal cap, which has proteolytic enzymes. The mid piece has all of the mitochondria, and then the flagellum, of course, is the whole thing that was created from a centriole, and it's the propulsion device. Is this diploid or haploid? One or two?
Diploid.
Haploid.
Haploid.
Haploid. It has one set of genetic information for every single protein to make another person. Okay, one gene for eye color, one gene for your nose shape. Okay? All right. All right. So let's just do a quick recap. Let me jump all the way back here and get to this one. All right, you ready for your pathway? Let's see, wait a minute, I better start here and then move out. Okay, so here we go. Seminiferous tubule 2, Straight tubule 2. Retestus 2. Efferent ductule 2. Hang out in the epididymis. Along comes orgasm. This is the sympathetic nervous system says, okay, we're leaving the epididymis. Where do we go next?
Duct.
Yes, the ductus deferens, the vas deferens. And then from the vas deferens, we go to the
Hold on.
Seminal gland?
well, through the through the seminal vesicle, through that, but that's not a change in its name. We're just going by this. We're actually, what's the name of this right here?
Ejaculatory duct.
Okay, from the ampulla is the end of the vas deferens to the ejaculatory duct into the
Prostatic urethra.
prostatic urethra to the
Membranous urethra.
membranous urethra to the
Spongy.
or penile urethra to out through the
External urethra.
external urethral meatus or orifice. Okay. Pathways, peeps, you know I'm going to ask. Just saying. Okay. So let's talk about hormones now. One moment, please. We'll get back to where we were about to be. Bam. Okay. So hormonal regulation in male reproduction. Okay. It's a coordination effort, as you already know. It's about hypothalamus, adenohypophysis, and the testes themselves, right? Okay. So the hypothalamus, when I need to do more in the department of making testosterone, what's it going to put out?
The gonadotropin.
Gonadotropin release hormone.
Releasing hormone, exactly. So gonadotropin releasing hormone, which then goes and talks to the
Anterior pituitary.
anterior pituitary or adenohypophysis, which says to it release two different things. What are those two different things?
LH and FSH.
Yes. Okay, so LH, its job is to talk to the interstitial cells, because what's their job? What do?
They prepare the body.
Oh, that is way too vague. Thank you for playing. I want really specific.
So the muscles grow, the bones.
No, you've gone past what they do first. You're not wrong, but you're too far downstream.
Okay.
Looking at the kindergartner and saying, what are you going to do in college? Oh,
Secrete testosterone.
thank you. That's exactly what it is.
Okay.
Okay, so LH goes to the interstitial cells. Their only job is to secrete testosterone. So the other name for LH is interstitial cell stimulating hormone, ICSH. Okay, FSH. Who's it going to talk to? Take a look at the picture. Who's this? Who's it talking to?
The sustentacular cells.
Yes, the sustentacular cells,
I
exactly.
said it right, yeah.
Well, I can't hear you unless I hear you. That was a very deep statement on my part, just so you know. All right, so they talk to the sustentacular cells, and they then release the androgen binding protein, which then says, okay, I'm going to take that testosterone made by the interstitial cells, and then I'm going to help with the process of spermatogenesis. So I'm going to make all this stuff happen. Okay. So testosterone then tells when the testosterone levels rise up, they say to the hypothalamus, hey, you know what? We're really okay. So you can now cut down on the gonadotropin releasing hormone. So we've got this. All right. So if we have a really high sperm count, then we've got more inhibin will be released because we don't need as much of the FSH and LH, particularly the LH, because we got this, right? So you recognize this feedback loop, that negative feedback loop. All right. Everybody good?
Yes.
Okay. So let's talk about the screw ups. testicular cancer. If someone gets testicular cancer, and there was a real poster child for it who then fell into shame because it turned out that he was doing naughty.
Lance Armstrong.
Yes, Lance Armstrong, yes. Testicular cancer, what they do for that generally is they do what's called an orchiectomy. Okay, so orchiectomy is because the other name for the testicles is orchid. Okay, because remember those flowers that I think I mentioned, that if you take your finger into the throat of the orchid and just pull it out, it'll give you this little pad with the two anther sticking there like little balls, and they look exactly like that. You can turn your hand upside down and they will stick to your finger. So it's great for the bee or whoever, moth, bat, whoever pollinates that particular species of orchid. Now it's got this thing stuck on the back of its thorax or head, and every orchid it goes into, now it pollinates. So anyway, guys, your testes are orchids. So if we take them out, it's orchiectomy. And they'll do radiation, chemo, whatever it takes. Sometimes they'll implant radioactive seeds down in the area. Cryptorchidism. Do you know what crypto means?
It's when one testicle doesn't descend, right?
Yeah. Yeah. Crypto means hidden, actually, is what it means. So, Tatiana, you're right. It's when one or both testes does not descend. Okay. So if that's not corrected, can the testicle or testes that are up inside the pelvis, will they work? No, they will not. And it puts them at higher risk for cancer. So you've got to either relocate them down into the scrotum if you can, that's preferable, or you have to remove them. Okay. Now, if you just remove one and the other one's down where it's supposed to be, nobody would know except the guy. And they actually they make fake ones to stick down in there so you don't even look like you've lost anything. They do that with
Do they put hormones in the fake ones? I know somebody who got spilled oil on their scrotum and lost both their testicles, and they put implants in his scrotum and they release hormones.
I have not heard of that, but it doesn't surprise me. But I would.
Yeah, he goes to the Mayo Clinic for it in Rochester.
Okay, well, he may have to, get reboosted, because you can get testosterone administered to you. I've not heard of having them incorporated into the pseudo testes, but anything's possible, I guess.
That's what he said, that they actually release.
Yeah, slow release.
He was burned very badly, so.
Oh my goodness, I don't even have those, and that just makes me wince. I don't know. Oh, that's sort of like that thing about the sternum I read at the end.
Yeah, no, this was actually his scrotum.
Oh my God. Oh, poor thing. Holy moly. Okay, well, on that happy thought, so orchidism, no, you never know, right? I mean, holy, poor guy. All right, so along that line, who's scraping around? Shelly, is that you? Nope, that's not you. Is it me? Nope. All right. So impotence, do you know what that means?
No sperm count, or not working sperm.
No, it's you can't get an erection.
Yes, it's about.
That's sterile. Sorry.
Yep. Yeah, sterile is you've got no sperm. Impotence is you can't get an erection. Okay, it's a plumbing problem. So, it's whether those corpora cavernosa and the corpus spongiosum, can they be flooded with blood, and can they then maintain it? All right, and then the last one is the prostatic hypertrophy. BPH is benign prostatic hypertrophy. That's the one where that prostate gets really enlarged. So we'll go back. Come on, back up here. So if the prostate gets enlarged, then you can't move urine through the prostatic urethra. And this happens with age with guys. It is one of the liabilities that men have to live with. So it's benign because it's not cancerous. And what they do is they do a transurethral prostatectomy where they open this up. But prostatic cancer is a whole nother thing. So there is a marker. It's called prostate specific antigen, PSA, and it's a blood test. And the plan is that you have really, really low levels of this stuff, like less than 4 nanograms per mil. It's not anything I'll ask you a number for, but I did have a student one time many years ago. It's been decades ago, but he called me up at home and said, Sue, I've got good news and bad news. And the good news is I have prostate cancer. So the bad news was he was going to go ahead and die because as far as he was concerned, he wasn't going to put his wife and his daughter into a fiscal bind by going through stuff. So anyway, he survived it. It turned out he was a veteran. So I said, seriously. So he went through and he got the treatment that he needed. You know, I recommended no surgery, instead just do, you know, radioactive seed things. They did that for him. And I saw him years later and he was just absolutely fine. So prostate cancer, just pay attention to it, guys, because you have prostates. Girls, bug the men you care about. All right. We're done with guys for the moment. Everybody okay?
I have a quick question about the cryptorchidism.
Cryptorchidism,
Only one testicle descends. Do they need the other one to descend as well, or can they just have the one?
You can't leave one in. So you need to they both need to either be down where they should be or out, because when you leave a testicle up, it's a liability.
Okay.
Okay. Yeah, it can go cancerous on you. That's just, you don't want to play that game.
Gotcha. Okay, thank you.
You're welcome.
Will it still function? If you have cryptorchidism, will you still get an erection and be able to perform, or is it no function at all?
If you've got nothing that's working there, I don't know whether, because we do make androgens in our adrenal cortex in that zona reticularis, but I don't think it would be enough. So I think you would have the quote unquote performance issues no matter what, but I'm not positive. I do know that if you have no testicles, you're not going to be able to do the normal things that a male would do. Okay. You got to have enough testosterone to do those things. You don't have to have sperm, but you do need to have, got to have the testosterone for sure. Okay. All right. So on we go. I'm looking in my book here, and we are now on page, let's see. One moment, please. My fingers are not working. There we go. On page 1061 is this picture. Okay. And so what I tend to do for this is I like to flip between this one, which is on 1061, and this picture, which is on, turn the page. Okay. So I'll kind of be back and forth. So I'm kind of going to start with this second one and go back to the first one, just because this one kind of does a better job of talking about the ligaments, our support system. When you look at a female's anatomy, it is an open system to the outside, and it's a very interesting way of doing things. In my opinion, a little less than optimal, because I don't know, I'd kind of like things sealed off a little better. But if you are a ne'er-do-well bacterium, let's say you're a little spiral thing called syphilis, Treponema pallidum, and you managed to get up the vagina because you came in a penis that decided to ejaculate in here. So now you go up the vagina through the external os of the cervical canal, through the cervical canal, internal os. Now you're in the lumen of the uterus. Pick a fallopian tube, any fallopian tube, you got two. So you go down through the fallopian tube, and this, at the end of the fallopian tube, is not touching the ovary. It does not hold it. It just hangs over it. And there are cilia that are creating a current to draw the egg in. So an egg could conceivably, well, actually, it won't get conceived, so it should be inconceivably, an egg will be released and it may not even get drawn into the fallopian tube. It may just get lost out into the pelvis. So my point is that because we have an open system and there's not even a direct connection of the ovary with the fallopian tube, we'd better hold everything in place very carefully. So in order to do that, we've got a lot of ligaments. There's one that's called the broad ligament. It kind of forms like a poncho or a tent over the uterus. It attaches to the sides and to the wall of the pelvis, the floor of the pelvis in that cavity. And it has a couple of different parts to it. It's all one big tent or poncho, but the one that is actually holding on to the ovary part is the mesovarium. It holds the ovary in place. And the mesometrium is the one that extends all the way along the sides of the uterus. So if we looked back at that first picture, you can't see those, but just know that there is this broad ligament comes over here, and this is what's going, kind of holding this in place like a poncho or a tent. Okay. All right. So then we've got, for the ovaries to hold them in place, we've got an ovarian ligament, which holds the ovary to the wall of the uterus. We've got the suspensory ligament, which really the suspensory ligament is like the spermatic cord on the guy, but it doesn't have a vas deferens, but it's got our supply line. So it's got the ovarian arteries and veins that drain are traveling in this. So it is holding the ovary in place with the supply lines, okay? For the uterus only, as versus the both, we've got round ligaments. The round ligaments will come down and they actually anchor down into the subcutaneous parts of the labia majora. Those are the outer lips that will grow the pubic hair. So these things, I guess, and the way I think of this is like, well, if you wanted to get on a trampoline, it's really nice to have something bracing down at the bottom so that you can bounce up and down and nothing will get out of shape. Okay. And then you've got uterosacral. Well, of course, if I'm uterosacral, I'm pretty much telling you I'm going from the uterus over to the sacrum. So you've got those on each side. And you've got the lateral cervicals or cardinal. So they're the ones that are going to go across and they kind of hold where the cervix is. Okay. So my point is there's a lot of structure to hold this all in place because it has to stay really carefully in place because the fallopian tube to bring the egg into the uterine area is not holding on to the ovary. Everybody got it? Makes sense? Okay. Okay. All right. So now we need to start talking about homologous structures. Remember, we had homologous chromosomes. The homologous chromosomes, whatever chromosome mom has, let's get our X here, I guess. I've got 2 V's, whatever. So mom has eye color and nose shape on this chromosome here and here. And then I've got dad has the same thing. They were homologous chromosomes that came together in synapses to form the tetrad, correct? So homologous means male version, female version of the same thing. So here's the interesting thing is that when we start out in the uterus as just a fertilized egg, a zygote, for quite a while, you can't tell what gender somebody is because the same structures are going to either go female way or male way, depending upon the hormones that are going to happen. Because if it's estrogen, we're heading off to the female. If it's testosterone, we're heading off to the male, but they start out the same. So they're called homologous structures. All right. So what do you think the ovary is homologous to?
The testes.
Yes, exactly. So we're going to go from there. Okay. So let's look at an ovary. So when you look at the ovary, it is constructed so that it's got the same tunica albuginea. Remember on the testes, that was that fibrous capsule. Ovary has it too. But on the outside of this is this layer of cells. They're cuboidal cells. And somebody way back when saw this and thought, oh, those must be the ones that make the eggs. So they called it the germinal epithelium. They were wrong. Nobody fixed the name. So it's a misleading name. It's wrong, but that's what they call it. Okay, so it is just something that's continuous with the mesovarium, part of holding the ovary in place so that it doesn't bounce around, so that it stays close to the fallopian tube. But it is not anything to do with germinal. It's just, unfortunately, they kept the name. Okay, so the germinal epithelium is on the outside of the tunica albuginea, which is the same as what we have in the testes. Then we have a cortex and we have a medulla of the ovary. Nothing new about that. The oocytes and the follicles having them are in the cortical region. The medulla is more in the middle. This particular picture of it doesn't really put a whole medulla in there. It's kind of an interesting cut through it. But anyway, so the follicle cells, this little single layer of cells around these guys that we'll get to in a bit. Anyway, these will surround, each little oocyte has its very own little packaging system, okay, of follicle cells. All righty, the medulla is where those veins and arteries and nerves all come in, just in the center of it, okay? Now back to, let's go to this one. The fallopian tube or uterine tube or even oviduct. Nobody ever calls it an oviduct in humans, ever. You're going to hear fallopian tube mostly. They may sometimes say uterine tube, but in the world of healthcare for humans, we call it a fallopian tube. Its job is to receive the oocyte from the ovary, and it is the place where fertilization will occur if we expect to have a successful pregnancy. I would know those facts. I will ask. Okay. You may get an egg fertilized elsewhere, but if it doesn't happen in here in the fallopian tube, it will not be developed enough to implant when it gets to the uterus. It needs to be at a certain stage of development or it will just be lost to the universe. Okay. All right. So anyway, there are parts to the fallopian tube. We have got fimbriae. These look like kind of fingers or fringy things. They have cilia on them. Those ciliated fimbriae, those fingers hanging over the ovary, not touching it, but they're creating a current to draw the oocyte when you ovulate, which is on day 14 of a 28-day cycle. There's another time frame you'll need to know. So when it's ovulated, it's released into the void. We grab it up with a current. We draw it in through the fimbriae. Then the infundibulum is kind of like the palm of the hand. So if you think of all these fingers are the fimbriae, and then the palm of the hand is the infundibulum. And then we've got the ampulla is this kind of end that's over by it's kind of like the wrist, okay? And then we just work our way down this fallopian tube until we get to the part where we're actually going to narrow down and head in through the wall of the uterus. So the name when we narrow up is called the isthmus, which is one of those really hard words to say because who puts us next to each other? That's craziness. So anyway, the isthmus and then the transmural or intramural portion, inside, mural means wall, okay? And then we get into the lumen of the uterus. So once you have ovulated and you've drawn this egg up with the current created by that ciliated columnar epithelial tissue, then what we have here is you've got, as you move along through the fallopian tube, we have some areas where we've just got some simple columnar, but they have lots of microvilli, and those microvilli are really just sort of about secreting some glycogen because we want to feed this oocyte as it's going along. We feed the cells around the oocyte. Now, we also have peristalsis because this smooth muscle here is going to make sure that we create a current of muscle contractions to move the oocyte along. And with any luck, according to your body, it may not be what you want, but your body is always looking to get pregnant because that's what its job is. We only exist, ladies, to make another human. And guys, you are nothing more than a way for a woman to make another person. That's it. Biology speaking, that's it. Didn't know if you knew that was it for us, but that is it. So peristalsis will move the oocyte along, hoping that it meets a sperm somewhere in this fallopian tube. Okay, we good? Okay. All right, so into the uterus. The uterus has, the majority of it is the body, okay? The fundus is this rounded part. That should sound familiar. Sounds like the stomach. So flashing back to this picture, the fundus is the part that aims forward, okay? You care a lot about the fundus because when you go through any of the health provider type programs, nursing, PA, whatever, be a physician, when you go through that rotation, whether you intend to have anything to do with pregnant women and babies and stuff at all, you still go through the general stuff. Well, this right here, this fundus, is really important in female pregnancy because for one thing, as this uterus fills up with baby, the fundus can be felt moving up above the pubic symphysis. And they actually can correlate how far up has it risen with how many weeks gestation is that woman. So it's a fundal height measurement. Another thing is that once a woman has delivered a baby, if there is too much bleeding going on, because there's an acceptable amount and there's an unacceptable amount. If you have an unacceptably high amount of bleeding, they worry about hemorrhage. One of the things that needs to happen is you need to get the uterus to contract. One way is for the baby to suckle because that releases oxytocin, which will make this cramp down, which means that the first breastfeeding is very uncomfortable. But the other thing is sometimes they have to actually do a fundal massage, which I had a student some years ago now, but she said, oh, wow, they did that to me. It was excruciating. And they just came at me and they didn't tell me what they were doing. So two things. One is if you massage this, it is a way to get it to cramp down in order to stop down on the bleeding. But the other thing, the bigger, more universal message is if you're ever going to do anything to anybody, even if you think they don't have a clue as to what you're doing because they're either confused or non-responsive, please think again. You always, always, always tell any human what it is that you're doing and why. Okay? Always. Otherwise, in my opinion, it's assault and battery. So you tell them. Okay? Promise me? Everybody. Okay. That's a big deal. Don't you ever do stuff to people and not explain. I felt so bad for that poor girl because she said, they didn't even tell me. And it was horrible. It was like they were attacking me. All right. So the fundus is a big deal. You want to know about the fundus. It's that front part sort of ballooning out, sort of like in the stomach. So there you go, the fundus. Because this one is the ovary sort of standing up and putting everything out. This is the actual placement. Okay. That's the real way it would be oriented in the body. Okay, uterine cavity is the lumen. I'm going to move back to this. It spreads things out better. So the lumen, that makes sense. Isthmus is where things narrow. So anytime I have a uterine isthmus, this is down here. It's where I got narrowed. Cervix, I've got internal and external os in the cervical canal. Interesting thing about the cervix that everybody wants to know is that when a woman goes for a gynecological exam, just a basic healthy annual thing to do, and they do a pap smear. Okay, it's a good Greek name, the Papa Nicolau, or however you say it. I'm not a Greek speaker, but anyway, it's sort of shaped like an oven mitt or kind of a mitten, and they scrape along here. And what they're doing is they're looking for abnormal cells. So if you have an abnormal pap smear, you get a call saying, would you come back and we'll just try one more time. But the wonderful thing, if there's a wonderful thing, about cervical cancer is that the way they diagnose cancer definitively is to take a biopsy, they take a sample. Well, when they take a sample here, what they do, it's called a conization. they take a biopsy, they get clean margins. Guess what? The biopsy proving what it is also the cure. We had a woman who was in her 30s who died of cervical cancer because she would not go, because it's not a dignified, fun thing to do. I've never heard of a woman who signed up for this to go and say, well, you know, just for grins, I think I'll climb up on a table and let you crawl around in my vagina. No, but it is a really important thing to do because you can't see up in there, ladies. You just can't. It takes instruments to get up in there and an expert to take a peek. So just do it. Oh my God. In this country, to die of cervical cancer and leave kids behind, that was a horror show. Oh my God. All right. So I guess I'll step down off that little soapbox for a few minutes anyway. All right. So looking at the uterine wall. The uterine wall has 3 layers. You've got your perimetrium on the outside. Remember, the perimetrium is actually kind of the serous membrane that covers the fundus and over to the posterior surface of the body. So if I look back on this one here, I have a perimetrium. Then you've got, it's just basically a continuation of the visceral peritoneum. Then we've got the myometrium, which is the big bulk of this. It is smooth muscle. Interesting thing about myometrium is that it is mitotic. Now remember, muscle, one of the rules of muscle is if you get in a barroom brawl and somebody takes a big bite out of your biceps, that's gone. We don't replace it. I use that example because I actually had a patient one time who that's exactly what happened to him. Waited 3 days before he realized it was really bad, came into the hospital. Oh, it was not good. But myometrium, because when you have an unused uterus, it holds about 5 milliliters. So picture 5 milliliters, it's a teaspoon. A full-on pregnancy, 9 months, holds 5 liters. That's 1,000-fold increase. So in order to do that, the myometrium is mitotic. This is smooth muscle. It's oriented in a variety of ways to allow for the stretching and then to still have the wherewithal to contract and push a kid out when the time comes. So it is truly a very thick muscular organ. So when a girl has menstrual cramps, this is not just all in her head. This is actually a Charlie horse cramp of an internal organ. It is very painful, okay? So picture that your calf just went up into a big old cramp and you can't do anything about it because your calf is now tied somewhere where you can't touch it, okay? Everybody good? All right then. Endometrium, the lining. So let's get to this picture, which in your books is over on page 1065. The endometrium is the mucosal lining of the uterus. It has 2 major layers. It's got the part that's going to stay behind. It's got the part that's going to build up and be shed or build up and become part of the placenta. Okay? So the stratum basalis, the bottom layer, the basilar zone, this is what forms the next functional zone. So it's sitting right on top of the myometrium. So this is always there. It builds up the functional zone or stratum functionalis every month once you hit menarche. Menarche is when you hit the age of having periods, okay, going through that cycle. So the stratum functionalis' entire job is to become the mom's part of the placenta. If you hit that phase of about day 27 and 28 of your 28-day cycle, and there is nobody saying there's somebody in here, keep it up, then this is the one that's shed. So a period, menstrual flow, is not just plain old blood. It's going to have clumps of tissue in it because it has this stratum functionalis of the endometrium. This has been built up so that it's full of little branches of vessels that will be lost too. It's fine. That's what you've done. You're building this up, and it's got glycogen in there. So it's all about creating an environment for a future human to embed into, get all their nutrients from it, and then turn into a functioning placenta. Okay, but if you're not pregnant, if there's nobody there who needs this, that's what's going to get shed. And it's the muscular contractions of the uterus that are going to push it out, and that's where the menstrual cramps come from. Everybody cool? All righty then. On to the vagina. So the vagina is a ridged structure. It's got very thin walls. It's probably about 8 to 10 centimeters long. It's extremely distensible, which makes sense because ultimately it's the birth canal, right? It's what the kid has to come out of. So the vagina is there for penis in, menstrual fluids out if there's no pregnancy, baby out if there is. So when you look at it, the vaginal canal has a fornix, which is this ring around the cervix. Now, here's the way to think about the cervix. And this was one of those epiphanies I had one day when I was helping with a patient on a bedside commode. So I apologize in advance. This may never leave your mind again, but picture an overweight old woman with saggy parts because gravity has been working on her for a while. I know if you have been a patient care tech or a CNA, you have seen this. So now picture that this old woman is sitting on this commode, the round seat, and the round seat. So you've got the female parts coming down through the central hole, and then you've got the rest of the butt and all that stuff hanging out the other side. So the ring of the toilet seat has pushed up. So the cervix is the part that's coming down. The fornix is that groove made by the toilet seat. And then you got the walls of the vagina coming down. So I apologize if you now have old, saggy woman private parts hanging on a toilet seat in your mind, but that's kind of how I visualize this thing. So the fornix is nothing more than entire circular grooves. They talk about the anterior and posterior fornix, but it's this circular groove defined by the cervix poking down into the vagina. Okay. So the vagina has rugae. Why would it have rugae? Yep, stretch.
Stretch.
Mimi did the perfect. Okay. So it's about stretch. Okay. And also, because these ridges are there, there is a certain amount of stimulation of the penis because, ladies, again, whether you want it or not, biology says the whole point of being here is to make another person. So therefore, when the penis comes in and out of this, the rugae, those ridges actually do help with stimulating the penis because that'll make them ejaculate. And that is what it is that we're trying to get when we are nothing more than a vessel for making another human. All right. There is a structure that is called the hymen. Having a hymen present has nothing to do with virginity. Now, granted, if you have a hymen, then I can guarantee that you have not engaged in any vigorous sports, including sex. It also means that you probably have never used a tampon. There are a lot of different things. So just so you know, because there are cultures who say, oh, after that first wedding night, you're supposed to hang your sheet out the window and prove with a little spot of blood that you were a virgin. And all the guys are hanging out below saying, I slept with her. Didn't you sleep with her? Yeah, I slept with her. Well, how did she become a virgin again? Well, some chicken died, because that's what they do. But anyway, it has nothing to do with virginity. The thing about having a hymen is that sometimes it's imperforate, which actually means that it doesn't have a hole going through it because it's supposed to be a partial membrane, not a complete one. So here's another story. There was a girl who had very definitely hit puberty. She was growing breasts, she'd gotten pubic and axillary hair, and yet she wasn't having any periods. So finally it was like, well, what is going on? So they took her to the doctor, And it turned out that she was having periods and she had menstrual cramp feeling, but she had a hymen that was intact. So when it got artificially ruptured, all this nasty stuff came down. And this was why she had this pelvic pain, because she was having them, but they were being retained up in there. So you want to make sure that if you've got a little girl, that's not an issue. That is one of those things that a pediatrician really ought to take a look at before they hit puberty. Okay? They won't appreciate it, I can guarantee it, but nonetheless, it's much better than having that happen to you. All right, so down at the base of the vagina, there are these things called vestibular bulbs. Now, in order to see that one, we kind of have to get down to this picture, which for you is in your books over on page 1066. All right, so anyway, this shows you the perineal region, that little diamond shape that defines where the female external genitalia is. But down here, this is what we need to look at, is on the right side. The vestibular bulbs are homologous to the corpora cavernosa. Okay, so these guys, their job is to be erectile tissue, which is back to the biology of getting what your body wants from the guy. When these engorge during arousal of the female, this makes the vaginal orifice tighter, which means that we're squeezing down on the penis, which means that we will get ejaculation to happen more readily. Okay, so these vestibular bulbs are homologous to the corpora cavernosa. They are erectile tissue on either side of the vaginal orifice. Am I clear? We got it? Okay, cool. All right. So when you look at the histology of the vagina, and we're not getting into a detail of histology, but right underneath the mucosa here, what matters is there are no glands that are inside the walls. Now, the walls of the vagina can kind of sweat, but in order to allow for intercourse, we need the bulbourethral gland or Cowper's gland secretion of the guy to lubricate the glans penis. We have glands up, the mucus glands up in the cervix, which will help from the top. And we also have, back here, we have greater vestibular glands in the female. They open up right at the external vaginal orifice. These greater vestibular glands, also known as Bartholin's glands, are homologous to the bulbourethral or Cowper's gland. So the female has their own mucus producing glands. Okay, so greater vestibular glands or Bartholin's glands are homologous to the Cowper's gland of the guy. All right, but the walls of the vagina do not have mucus production. They just kind of can sweat a bit. All right, so the function of a vagina is it's the female copulatory organ, so penis in. Then we either are going to have a baby out or menstrual fluids out if we didn't get fertilization. The other thing that we care about is, and this is that HIV and STD, or sexually transmitted infection, STIs, they call them now. But right underneath the mucosa of this, you are going to have those dendritic cells. Remember, those are the macrophages of the immune system. They're going to be presenting. They eat and present. So if you have someone who introduces HIV into the vagina, intercourse will always cause a bit of bleeding because it's friction, just as plain friction. It's going to cause some issues because you've got non-keratinized squamous epithelium in this vagina. And so therefore the dendritic cells will be exposed. And if there is somebody nasty like HIV being deposited there, those dendritic cells will take up that nastiness, will present it to the helper T cells. And remember, HIV selectively goes for the helper T cells. Remember this? So Ladies, if it is wet and it is not yours, you proceed with caution. Okay. All right. So back to this picture. This is what a gynecologist looks at for their trade. I don't know about you, but that's not what I'd want to spend my days looking at, but there you go. So the mons pubis is the pubic mountain. It's got the fat deposit on it. This is where you're going to get the pubic hairs. You've got the labia. So the external labia, the labia majora or labrum majus, these are homologous to something on the guy. Can you guess? Anybody?
Testicles, like the scrotum part?
Scrotum, exactly. You got it. It's the scrotum. So the labia majora are homologous to the scrotum. What do you think the labia minora or labrum minus would be homologous to? Think about this.
Glans penis?
Corpora cavernosa.
Vaginalis, with tunica vaginalis.
Nope, not neither of those. What else?
Spongiosum.
Nope,
Cavernosa. Corpora cavernosa.
nope. I'm going to have to tell you, it's not logical. Well, it is logical, but it's not obvious. How's that? So here's the deal. The labia minora are homologous to the underside of the penis, the ventral side. Okay? So here,
Oh, that makes sense.
it does, because we're going to turn this into a boy. You ready? Okay, so let's finish up the details and then we're going to turn it into a guy. So the labia minora are homologous to the ventral penis. The shaft, the ventral side of the shaft of the penis. What do you think the clitoris is homologous to? Its name tells
Glans penis.
glans penis.
There we
Here's
go.
where you've got the corpus spongiosum.
Okay.
Okay. All right. So ready to make a guy? So here we go. Watch this. So here's what I'm going to do. I'm going to go over to that first picture here. Okay. So watch. Here we go. So we've got the greater vestibular or Bartholin's glands. So we've already got our bulbourethral glands, right? So they're ready to secrete. We've got, if we take the labia majora, we zip them together and we bring the ovaries down into those. Then we take the labia minora and we zip those together. The urethra, see here it is, the urethra then would travel up that tube. We pull the clitoris forward and we've got the glans penis. So you've created a penis. You've already got your vestibular bulbs on either side of the vagina. So we just have to zip up the vagina because guys don't have anything homologous to that. There's no analogous thing. So anyway, but can you see how we could, kind of zip things up? We got ourselves a penis, just draw this forward. Now this is, please don't think that this is how we create, if you do a transgendering operation, that I don't believe this is how you do it, but just think about in the world of the fetus, right? We've got, this is how we could pull it together. Cool, right? So if you can visualize that, then you will know the homologous structures when I ask. You heard the when, right? Not if. When I ask, I will ask. Okay, cool. All right. Okay, so now, let's see, next.
I have one quick question.
Yes, indeed.
So you said for females, for like sexually transmitted diseases, that means it's easier for a male to pass it to a female.
Oh, yeah.
Can a man get HIV from a female? I know they can, but it must be much harder.
It is much harder. Men are better designed for not catching things. They're much better at giving.
Okay.
I'll tell you, the safest sexual orientation or, for anybody, the safest personhood is honestly, other than celibacy, I guess you could, just plain old lock yourself somewhere and never interact with anybody, which we're getting close to that right now, but not quite. But the safest one is to be a lesbian because they have the lowest incidence. Guys, to be actually the most dangerous is homosexual male, to be a guy, because guys have a much stronger sex drive and they will do things that no woman would venture to do and put things where they just would never have things put. So it's harder to catch something if you're a guy, but it's pretty easy to give something. So if you're willing to be a recipient in certain places of your body, then it sets you up. The rectum is a very friable place. Remember, the rectum is still about reabsorbing, so it's very thin, it's simple columnar. So anal intercourse is a problem because it will make them bleed, and then it's a perfect place to introduce anything. Okay, does that make sense?
Mhm.
Okay. All righty then. So moving on, let's talk about breasts. Mammary glands. All right, so mammary glands are present in males and females, just so you know. We actually had a man, and this is on page 1068. We had a man who died of breast cancer. So you can get it regardless of your gender. As a matter of fact, there's an interesting phenomenon when little babies are born, when neonates, they come right out of the oven, and it's that fetus has been exposed to all the hormones that mom is exposed to, and they call it witch's milk because there'll be this little like skim milk coming out of the nipples of the baby, male or female, because they've been exposed to mom's prolactin levels and all that stuff. So you can see that males and females both have breast tissue. All right. So anyway, we only get this functional in a female if that woman gets pregnant, okay? Unless there's some kind of a tumor thing, in which case all bets are off. But all right, so when you look at the breasts, the size, the bra cup size, A, B, C, D, is related to the amount of fat, assuming it's done normally. Otherwise, you can have artificial ingredients, I guess. I'm not a fan of artificially doing anything, but whatever. I guess people make choices. But that's about adipose is cup size. All right. And the structures that matter, because the only reason we have breasts, ladies, is to feed a kid. That's really the only design for it. It's the rest of it is cultural, but it's just to feed a kid. That's the only reason that it's lactation. So interesting thing, the glands are actually modified sweat glands. So what we're feeding kids is modified sweat. So that's kind of an interesting thought. I gave you the sweat off my breasts. It's a new line for your kids. It'll traumatize them. Don't really say that. So the nipple is the part that sticks up. The areola is the pigmented area that's bumpy around it. It's bumpy because it's got some really large sebaceous glands. It's important to oil this up. And the reason for that is that when it's serving its purpose, there's a wet, germ-laden mouth that goes on this. And so in order to keep this lubricated so it doesn't dry out and crack, and then you have mastitis because you'll get an inflammation in here, an infection. But it helps lubricate it, and remember that sebum has antibacterial properties, right? Lysozyme, it's acidic, that stuff. So it's bumpy because of those big sebaceous glands to try and keep the nipple moisturized, especially for feeding. The autonomic nervous system works on this in order to take the smooth muscle and make it contract. And that's why when you're cold or you're stimulated, your nipples stand up. Okay, it's all about your autonomic nervous system saying, "Oh, it's cold," or "Oh my goodness, this is stimulating." All right, so looking at the structure in here, you only develop this if you are nursing. Otherwise, it stays in a very rudimentary state. So you have these lobes that are separated from each other by these little fibrous connective tissues and fats. So you've got these lobes. The lobes have lobules that contain alveoli. Alveoli, in this case, their job is to make milk. Okay. We've got ducts that carry the milk towards these swollen things. And whenever we've got a swollen thing, one of the words we like is sinus. So we've got lactiferous sinuses. Then we continue our lactiferous ducts and they open out to the surface. You have lots of ducts. This isn't like some bottle with one small opening. This is a bunch of little openings coming out at the same time. Okay. Everybody okay with this? Okay. All righty. So why do we have breasts? One reason,
Feed children.
feed the kid. All right. And by the way, in case you were ever wondering, you can actually produce milk for as long as you have enough health. As long as you keep stimulating the nipple, if you ask for it, it will come. I have a very close friend who kind of an earth mama. Excuse me. But anyway, she was still breastfeeding her 4-year-old. And I just sort of feel like if somebody can come up to you, lift your shirt up and ask for it, and they have a lot of teeth, I'm just thinking no. But I never reproduced, so what do I know? But I just thought, no. But we use that with cows. You get them pregnant, you get the calf, and then you've got a milk production until you stop asking for it. So as long as we keep stimulating it, it'll come. If you do want to stop breastfeeding, you have to stop all stimulation. So that's where the woman has to get, like, I gather that bags of frozen peas are the very best thing to cool it down so it's not quite so uncomfortable. Really supportive bras so that there's nothing stimulating the nipple. It's the only way it'll die down, because as long as you keep stimulating it and asking for it, you will keep producing milk. All right. So how is it we produce milk? Do you remember all those wonderful hormones?
Prolactin.
Oh, yes, absolutely. So the adrenal hypophysis releases prolactin. It also releases growth hormone, because remember, we started out with rudimentary glands. We have to grow more. So growth hormone and prolactin. We also, when we get the placenta going, you actually have something called human placental lactogen. So we've got hormones that will stimulate the growth of this. Postpartum, it's all about prolactin continuing as long as you keep asking, and then good old oxytocin for the milk letdown reflex to stimulate release of the milk. Everybody good? Does this sound familiar? Okay.
Okay, I have a quick question.
Yes, indeed.
So, I know you said you don't have kids, but if you're breastfeeding, your body, you're pregnant and your body is reducing or sending off all these hormones, the prolactin and whatnot, and it's causing the milk to build. When is this is the reason why a woman's breasts become enlarged and what they call engorged, so to speak. Is that why because you were saying something about the frozen vegetables?
Yeah, if once you've started down the road of you are making milk because there is another human that is requiring food, right? And you're in charge of making the food, then you'll continue to fill. It's like, I don't know what you guys know about cows actually, but I have milked cows. I learned how to milk cows when I lived on a farm in Ireland as a kid. And they get really big udders as every morning as they're ready to be milked. Well, we're mammals too, so the same thing happens to females. If you need to stop delivering milk because you're no longer breastfeeding the child, then the only way past that is you're going to get engorged, and then you have to not let it come back out. You need to make sure that you're not stimulating the nipples so that it will stop production down. Is that what you're asking? Because that will then cut down that hormonal feedback. Okay.
I think I kind of understand it. I know when I was pregnant and breastfeeding, I was extremely engorged. So they were telling me to not just pump, they were telling me to use the frozen vegetables.
Yeah.
So it would, I guess, slow it down because I was so engorged at the time.
Right. You were trying to slow it down.
I know they kept saying that my son was not taking in what basically I was producing. I don't know.
You were overproduction.
Okay.
You were just an overproducer for an underneater, underutilizer.
You can make a lot of money doing that.
Yeah, you actually can. There's a huge need for breast milk because there are a lot of women who have the opposite problem where they just can't. Back in the day, they called them wet nurses. You would have somebody who had their own baby and they produced enough so that they could feed somebody else's kid too.
I heard about that. Okay. Well, thank you for
Sure.
kind of understanding that concept.
Well, okay then. No problem. Yeah, there are a lot of things I know that I never had to go through. So that's going to be true for all of you. And it already is. I just don't know all the things you know, but you know a lot of things that you never had to do yourself, right? You don't have to jump off a bridge to know that it'd go splat and hurt. So there are a lot of things, a lot of things that we know. All right.
I have a question.
So, huh? Clayton, you have a question?
Even though we passed like the vagina part, how does birth control work?
Oh, we're going to get to that actually. So you hang on, because I am actually going to explain exactly how that works. Okay. All right. So I just want to show you a mammogram, and since we're not together, I can't pass around all my different interesting mammograms. I even have mammograms from somebody who has implants. That's kind of interesting. All right. So anyway, what you don't want to see is interesting on a mammogram. All righty. That's another thing. Get your mammograms once you hit a certain age. It depends on your family history, but you need to make sure that you get that taken care of. Okay. Keep up with it.
Aren't mammograms like really painful?
They shouldn't be really painful, but let's face it. Here's what's happening is they take your breast and they put it between two plates and bring them together. And the flatter that you can tolerate, the better the image is. Okay.
Oh,
Now, I will tell you that what I've heard, because, I've only got what I've got. I've never lived in anybody else's body, that at least not that I remember. If that's possible, I don't know. But anyway, they say that when you're very small breasted, that it's more uncomfortable than if you have large breasts. And since I am in the former category where there's really not much of anything, they have to work really hard to pull stuff over to find something to grab and squash.
Yeah.
And I find it tolerable totally. Okay. So if I can stand them trying to find stuff from the backside of me, I'm pretty sure they try pulling from my scapula when they do it.
Okay.
Then you would be fine.
Okay.
I get one done every 6 months because of my family history, and they are not. It's like if you pinch yourself, or somebody pinches you.
Yeah, I don't know if I'm particularly worried about myself, but
it's really not that intense.
It's not. The worst part is it's cold.
It is.
Why they haven't figured out how to heat them is beyond me.
It is very cold.
It is.
I agree.
All right. Listen, I just wanted to at least get through the meiosis part of this before we quit, because we've kind of sidetracked on some cool conversation. But can we get through this piece so we finish the whole process of meiosis? Would that be all right?
Yeah.
Can you stand it? Everybody okay? All right. All right. So we already understand meiosis in general, so let's go through the difference with females, okay? So with the girls, we still have meiosis, but it all happens before you ever step foot out of the womb. You, as a fetus, all that you have in the world of eggs is all that you're going to have. Mitosis is done. Meiosis is in prophase 1. Every single one of your oocytes is sitting in prophase 1. You need to know that. So in other words, synapses, tetrads of homologous chromosomes have occurred. They're sitting there in a state of suspended animation. So every single egg you have, your 100,000 eggs, they're sitting like that. Okay, ladies? So, and they're sitting in these little thin-shelled things of little flat cells. They're called primordial follicles. And those little follicular cells are just one little thin sheath around them. So they sit in clusters like a state of suspended animation. Then what happens is at menarche, which, whenever it is for a girl, some start at 8, some start at 15. It just depends, okay? But anyway, after that, what happens is with FSH coming along, you will start tapping on certain of your primordial follicles. They will then start the process of meiosis a little farther along. The actual follicular cells will start to grow. They get bigger. They make more layers of themselves because they're about to become the corpus luteum, luteinizing hormones. They are an endocrine gland. Okay. What's going on in the oocyte in here is it finishes meiosis 1 and then goes into meiosis 2. But it's only going to make it at the end. It's only going to make it to metaphase 2. In other words, where it's all single file lined up. That's as far as it ever gets. When you ovulate in the middle of your ovarian cycle on day 14 of 28, your oocyte that's released is in metaphase 2, single file lined up. Eggs, because they are the repository of all of the organelles for the next human. All sperm deliver is DNA. That's all. So the Golgi, the mitochondria, the endoplasmic reticulum, everything that a cell needs, organelle-wise, has to be in the oocyte. So when it does its meiotic division, meiosis 1, it keeps all of the cell stuff together and just ditches half of the chromosomes. The part that is gotten rid of is called a polar body, the first polar body. It tucks it up under its little cytoplasmic membrane. It's kind of like, I think of it as taking junk, putting it in your back pocket. I don't care what it does. It's garbage in my back pocket, whatever. Okay, so it's a very unequal division at the end of meiosis 1. It will never, ever, ever finish meiosis 2 unless it gets fertilized. Fertilization doesn't mean sperm meets it. Fertilization means that the chromosomes of the sperm get inside the egg and start mitosis. Okay? So no more mitosis in the ovary after you're born. It stops before you're born. All the little oocytes are sitting in primordial follicles, single-celled chambers, in prophase 1. If it gets stimulated, because we just start stimulating 1 or 2 at a time, we continue the process of meiosis, making it all the way just to metaphase 2. We ditch a polar body. These cells that are the packaging system are getting larger and larger, starting to build a blister. The blister is follicular fluid made by follicular cells sitting in a chamber called an antrum. Because here's what we're trying to do. We're trying to build a blister that will go and pop out this oocyte in its little package. And that's what's going to be drawn in by the current of the cilia on the fimbriae of the fallopian tube. That makes sense to everybody?
Can you say that one more time?
How much of it?
The last 2 sentences before that.
So now I'm not even sure. But what happens is, let's go with the cells around the oocyte. So the oocyte, it's sitting in a primordial follicle in prophase 1. It gets tapped by FSH, says your turn, you go through maturation. The oocyte is working its way through meiosis 2. Okay, end of meiosis 1, I got rid of the first polar body, which is half the chromosomes. Now I'm in metaphase 2. I'm building up a blister of follicular fluid, so I'm going to be able to pop. You can actually see a mature or tertiary or Graafian follicle with the naked eye on an ovary. It's like a blister, and it goes and it pops out, and this oocyte that's sitting in a cluster of its own cells called the corona radiata, radiating corona crown. This is what gets released, and it's drawn up by the fallopian tube. These cells, these outer cells that are left behind, this ruptured follicle becomes an endocrine gland called the corpus luteum. It makes estrogens and progesterones. Okay, does that make sense? So it does meiosis, but it does it in a very staggered way. So we've got mitosis to meiosis, prophase 1, then we sit. And we may never get chosen. We sit. And if we are chosen, our cells around us grow. They're starting to make estrogens. They're going to make progesterone later. They're going to make a bubble of fluid, follicular fluid, build up a blister so I can go and pop out and then get drawn up. Okay. So when I look at this egg that's sitting in here, it's sitting in metaphase 2. It's got one polar body, the first polar body, the extra genetic material that it'll never use. It's garbage. It'll dissolve over time. It's still got too much extra information, but it's going to finish meiosis only if it gets fertilized. If I am a sperm and I am trying to get through to fertilize the egg, I have to get through this corona radiata, through a little zona pellucida, that little gray line there, and get to the oocyte. So if I'm a sperm, do I want to be first on the scene? Think about it. No, because remember, each sperm has its own little acrosomal blasting cap. So when you look at from the sperm's perspective, when it's trying to get to this oocyte, because here's what they look like. Look at this. We've got, if I want to fertilize this oocyte that gets released, I don't want to be the first one because I'm going to waste my blasting cap on this corona radiata. And I don't want to be second either because I'm going to waste it on the next layer and the next. I don't want to be here where I'm going to hit the zona pellucida. So it's all about, in those bicycle races, like the Tour de France, where you've got people and they're in their packs and you want to be the one drafting and then you come through at just the right time. That's the way this works. You want to be the sperm who shows up just at the right time so that you're the one who is there at the right time and nobody else is there. Okay, does that make sense? It's kind of an interesting thing. So ladies, we are very cryptic. We got all these oocytes sitting there in suspended animation. It's also why if you're 50, you really don't want to use these. Your eggs are 50 years old plus a few months because they were ready before you were born. They're old. Okay, even if you haven't hit menopause, you don't really want to use these. These are from the back of the refrigerator growing the fuzzy green brown stuff, and you just don't want to use those. You got me?
Excuse me, how they are usually collected for the implantation or like?
They give them, well, what they do is they give them hormones so that a bunch of these primordial follicles will get stimulated. So you get a bunch that go through the primary, secondary, tertiary, mature. And so you'll have a bunch of blisters all over the ovary. And then what they go in is they actually have to surgically go in and harvest them. So they go on up in and get it. Yes. Now they don't cut through the woman. You remember it's an open system. So you snake up through the vagina, through the uterus and down. But oh my, yeah, it's not comfortable whatsoever. They go harvest.
Laparoscopy or?
Pardon?
Is it gonna be a laparoscopy or, I mean, surgical?
No, they can go on up through. We're open up. Remember, you can go up through the vagina and work your way. So they can do it with a retrieval system that way. They don't have to cut through somebody.
It should be like a hysteroscopic procedure.
Yeah, exactly. They're going up and looking while they do it.
Right.
Okay. But it's no fun whatsoever. I do know somebody who had to do that. Her husband had an extremely low sperm count related to trauma when he was a kid. So they had to harvest her eggs so that they could very carefully cull through and find 1 or 2 sperm and then get the 1 sperm and get it into the egg so that they could make a zygote. So, yeah.
Is that the same process they do for IVF as they do, right? The same thing. They just don't harvest the eggs. They leave them. Okay.
They can, or usually they'll harvest it. If it's in vitro fertilization, they have to take them out in order to harvest them. Yeah.
Oh, but can you just do make them a lot and then just, that could be a way to.
And then hope that you get more. Yeah, you could do that. Absolutely. It's all hormonal treatments. It's no fun. It's a lot of injections for the woman.
But it's only the woman. The man can't up his sperm. I mean, other than wearing boxers or something, they can't. They can't like make more sperm or make their sperm more functioning anyway, right?
Right.
Okay.
That part will, if it's a guy's problem, the girl's the only one who has the chance to.
Okay, that's what I thought, but I wasn't sure.
Okay. All right. Well, it's pretty cool stuff, right? Making sense?